I'd like to introduce myself. My name is John Finicos. I'm a pharmacist here at the Brigham and Women's Hospital. I've been here for 27 years now. I was actually born in the hospital. So there's a special meaning for me here, and I truly expect to be here for the rest of my career. And as an aside, like most things when you work here, I've got just about every organ system covered, so if something goes wrong, I have a doctor that I can consult with for advice and information. I'm going to run in with some comments to begin the program because I expect there'll be people that'll be coming in and out as I start because of various things like, I know it was raining this morning, traffic is always an issue. Finding where the coffee is and where to sign in is always an issue. So if you'll indulge me for a few minutes, if I was sitting in your seat, and I have a million times, the first question is who are all these people hanging on the walls, right? And I will tell you, to me, this is a very hallowed, holy spot in the hospital because it's a reflection of centuries of learning and education. And I can tell you that we are in the Bornstein Amphitheater, okay? And of course, this is a question I would pose to my children, right? Who's married in Grant's tomb, right? What city is responsible for Boston baked beans, right? So, so who is the Bornstein Theater named after? Exactly. Now, and this is the second question I would ask my children is, can you name everybody in the room? Yeah. So, yes, it was Mr. and Mrs. Bornstein that donated the room and the renovations for it in 1993. And he was a chemist in the Boston area and actually did a lot with narcotic drugs. That was his specialty. See, Dr. Goldhaber has arrived, so we have to wave. And in his benevolence, he put the funds to renovate the room and set up many of the portraits. I'll also tell you that his child was stricken with cancer and is actually treated here in the hospital, and that's why it's a special place. I can tell you that on the wall here we have a Nobel Prize winner, Pulitzer Prize winner, somebody that came from Transylvania, Hungary, from the Soviet Union, a graduate of Yakima High School in Washington State. I mean, isn't that as far as you can get, right? Of course, the Harvard Medical School dean, nurses, and a farmer. And if you'll give me a minute, of course, the Nobel Prize is probably the big thing. And in the back here, if you happen to go through our lobby, you'll see the Nobel Prize in the Peter Bent lobby was won by Dr. Joseph Murray. And the three physicians in the back also had incredibly important roles in the first renal transplant that was done in the world. It was done here at Brigham and Women's Hospital. And more importantly, from that one kidney transplant emanated all the other transplants that are done in the world. The heart, the lung, things like the pancreas, and even the bone marrow. The individuals that were involved actually migrated to Washington State, and Fred Hutchinson Medical Center in Seattle did the world's first bone marrow transplant, and from physicians that actually started here at Brigham and Women's Hospital. And if you read the newspaper just recently, the donor, the brother that received, there were twin brothers, the brother Ronald Herrick that received the renal transplant died after about 10 years. The donor brother just passed away a few weeks ago. He lived in Maine and was on the staff of University of Maine College. When I hear that story, the person that I'm always most interested in is actually not the folks that did that actually worked on the stricken individual, but Dr. Hartwell Harrison was actually responsible for taking the donor kidney. So if someone was under stress, wouldn't it be the person that was working on an individual that was perfectly healthy and probably could have had something gone wrong? We have a Pulitzer Prize winner, Harvey Cushing, who did enormous amounts of work in the turn of the century in neurologic diseases. He has a syndrome named after him. It's related to pituitary illness. He actually won his Pulitzer Prize for his illustrations because we didn't have computers back then. And all of his medical drawings were actually recognized and given an award. Soma Weiss is the chief of medicine here at the age of 42. So a young guy was brought all the way from Europe and then here to Brigham and Women's Hospital to become chief of medicine. And he died just after a few years at the age of 42. He was generally recognized as an incredibly intelligent man. Dr. Simon Gelman, who was for many years chief of anesthesia, came and was educated in the Soviet Union, and then came to Cleveland Clinic and then migrated here to Brigham and Women's Hospital. Obviously, the question that most people ask is who's the guy with the beard in the background? And I can tell you that's his grandfather. He was essentially an uneducated, illiterate man in Russia. And as Simon says, you know, I am the son of basically a farmer, and now I'm a Harvard professor. So how good does that get? The sky is the limit. Dr. Manek, who was chief of surgery for many years, came from Washington to Harvard and trained, was chief of surgery. You'll still see him periodically. I still see him walking through the hallways. And the school, of course, Henry Christian was dean, and back then the college is attached to the medical school, so there's a dean here as well. And there are nurses. Carrie Hall, that's her name, was the founder of the Peter Bent Brigham Nursing School that trained nurses for many, many years. And she was followed by Marion Metcalf, who just recently passed away and was one of the board of directors here at the hospital, the trustees. She was also on the boards of trustees for many of the colleges, the School of Medicine, the School of Pharmacy, etc. And then finally, I'll regale you with William Councilman, who was also chief of medicine here. He came from the Baltimore area. He grew up on a farm and trained at Johns Hopkins and then came to Brigham and Women's Hospital. And the interesting story about him is back then he used to plant shrubs and flowers around the Brigham and Women's grounds. So not only was he an expert physician, but he was, still interested in farming from his childhood. So I put these up there because, like I said, it provides us with a little time. And of course, if you were sitting there, I always say the same thing. Boy, I ask myself, I wonder what I would look like in a portrait here. And unfortunately, I've had the benefits of some of my, I don't have an artist, but I do have 3 children. And this was one in the 3rd grade from my daughter, Grace. I said to her, I can't help, Grace. I have bandages on. I see my ID badge, and I have a tie. I said, but I think I look like a scarecrow. And she has said, of course, Dad, you're a pharmacist. So that's pretty obvious, isn't it? Who's the most important of all these people in the room? I would say it's you are. Okay. First of all, I thank you for coming. From the bottom of my heart, I thank you for coming to this meeting today. While all of these people that hang on the walls have made enormous contributions to medicine, it's actually your contribution. When you come to us here at the hospital and you tell us your story, and we can take that information from one individual and try to benefit many individuals, the importance is not really on the clinicians here. I would tell you it's on the patients that bring us the information and allow us to improve treatments for everybody that we see. So I hope you'll keep that in mind and that you'll ask questions during the course of the day. I'm responsible for the welcome and introductions and the small attempts at humor during the course of the morning. We'll talk a little bit about medications, specifically about how well we adhere or comply to the medications that are prescribed as patients. I'll talk a little bit about patient safety. I'll be followed, again, we're hoping we have plenty of opportunity for discussion. And then immediately following me at 9:30, Dr. Goldhaber is going to talk about warfarin and some of the new anticoagulants. This is a very, very exciting time for us that are involved in anticoagulant therapy because really, for the first time in many decades, we have alternatives to the drugs that we typically use. Again, discussion in QA, and then we'll take a break. Okay, we got about a 20-minute break at 10:30 built into the program. At 11 o'clock, David DiCiccia, who you may know by talking with him over the phone. You may know by seeing him in person, as one of our clinicians in the Anticoagulation Management Service. And so he's going to talk to you about lifestyles related to taking the drug Coumadin. He'll be followed by another pharmacist, Cheryl Silva, who has been working for many, many years here in our anticoagulation clinic. And now she's so popular, she migrates between Brigham and Women's in our clinic, or our outpatient clinic in Foxborough. So she's doing dual duty. And you can talk to her about home monitoring and INR testing. Ruth Morrison and Catherine Mickelson, who have for many years, Ruth has been a nurse here for as long as I can remember and worked with Dr. Goldhaber and other doctors in terms of trying to improve management with thrombosis. Catherine Mickelson is with our North American Thrombosis Organization, and they're going to talk about pulmonary embolism support groups and hopefully and DVT support groups, and hopefully we can get you involved in those activities here at the hospital. We'll have an update from Carolyn Kernan and Al Howe, who again work out of the nonprofit organization, the North American Thrombosis Forum, that many of us spend a lot of time in, and again, reaching out to patients and trying to improve the care that we deliver. And again, of course, questions and answers. And then finally, probably the most important thing is lunch, right? For those of you who need that, and it's available. Now, for some housekeeping details as we move through this, there are restrooms here in the building. They're hidden, so people can't find them, and you walk around and get tired and need to get food or other things that we can. The restrooms are, again, if you exit out of the Bornstein Amphitheater and walk down the hallway, there are restrooms on your right about 25 yards. There are restrooms on the first floor of the lobby. Okay, so those are the closest restrooms that are available. We have parking vouchers. So there should be, one of the big challenges here at the hospital was to find a parking space, right? Even though we have valet service, parking is always a challenge. Traffic is always a challenge. There are parking vouchers today for you. If you haven't picked one up, they're at the registration desk, and your parking will be covered today by the hospital. If this is the worst program you've ever attended, okay, because yeah, sure, you've sat in bad movies, right? You need an exit strategy so no one knows. Most of you don't. Cell phone ring. A beeper goes off. If you need to leave here today for whatever reason, if you walk up the stairs and through the back, there is a stairway that goes down one flight and exits into the hallway. So up the stairs, down the stairs, out the door, take a right, and you'll be out in the hallway. So if you need to exit out of here early on, that's the strategy. I'd ask you to silence your phone call. You saw me doing it here early on because mine goes off routinely during the day, and that would be helpful. We have a computer out in the hallway, right? When people's minds start to wander, they say, oh, I haven't paid a bill. I need a computer, and I need it right away. We have one in the hallway. If you need internet access, we'll get it for you. And then finally, we opted not to prepare handouts for this meeting for the sole reason that is the route that most organizations, educational programs are headed right now. If you wish to have the handouts for our program today, they'll be located on the NATF, the North American Thrombosis Forum website, and you can either download them and secure them on a computer, or you can print them. You go to a library and print them. They'll be readily available for you. So I want to thank on behalf of our anticoagulation management service, of which Dr. Goldhaber has an important role in directing. Gene Connors, one of our directors from the Dana-Farber Cancer Institute, and all our nurses, pharmacists, students, our cooperative students that come from places like Northeastern University. I'm going to give you the microphone right now. Yeah, there's plenty. There's a couple seats in the corner on the left. Yes? You're going to lose, my friend. You're close to the door. That's if there are others, I don't have this was not built with, wheelchairs, crutches, other things accessible, so you'll have to exit out the front door if you need it. And we'll have people going, I recognize that, during the course of our meeting. So anyway, folks that brought you the program today. Okay? So I think we're right on time. Any questions at this point?
We have two of the handouts.
What else do we have? If there's a program, we can get you those. I think you're going to see a lot of slides today with graphics and figures and pictures. And those we didn't make copies because typically it'd be about 40 or 50 pages. And it's easier, we've found, for people to just go access the internet and capture the slides on that setting. So we'll have those available. Other questions? So far, so good. Okay. So we'll have people, like I said, if you can tolerate it, we'll have people coming in and out during the course of the morning. And so let's start. That wasn't too bad to begin with, was it? No. Yeah. If I had more time, I would regale you with more stories of the infamous people. My role this morning for the next 15 or so minutes is talk a little bit about medication adherence. And it becomes more important, becomes magnified because of the new drugs that we have tend to have a much shorter duration of action. And if you don't take them, obviously, there could be problems. So my focus today is to talk primarily about medication adherence and some of the things that may be important to keeping on track with your medications. It's not uncommon for patients here in the hospital to leave with as many as 14 or 15 different medications that they have to take. And that's why I say you need to keep this in mind, to keep strategies in place to be able to get these drugs on board on a routine basis. So my outline of my objectives this morning is to talk a little bit about medication compliance, or what we refer to as adherence. We're going to talk a little bit about what we found here at Brigham and Women's Hospital because I think it crystallizes what actually happens to many patients, not only here in the hospital but outside of the hospital. We'll talk about the scope of the problem and the barriers, talk a little bit about some new options, and then we'll talk about next steps. And then finally, I'll switch gears for a few minutes and talk a little bit about patient safety and what the FDA is doing. Well, I never start a program without telling some sort of story about my family, and this one is about my grandfather, who is like Dr. Gelman's grandfather, an immigrant from the country of Albania. He came to the United States with absolutely nothing and managed to have 6 children, 20 grandchildren. Half of them went to Ivy League schools. There's a couple of doctors, 3 pharmacists. I could regale you with the stories. But in the late 1980s, he had gotten sick and developed congestive heart failure. He was on a number of medications, including warfarin for atrial fibrillation, and struggled with it. And his health had deteriorated to the point where he became anemic, and back then you would be admitted for a 5 or a 10-day stay at the hospital, and that's where he was admitted to and was going to get worked up for some pulmonary edema and to find the cause of his anemia. Well, when my grandfather was here in the hospital, he had been told, of course, that you should stay away from green vegetables. And when he was here, the dietitian came and saw him and said, we need to order some food for you, and provided him with a menu. And on the menu, of course, was pea soup. And my grandfather recognized immediately he shouldn't take this and said I politely declined. But when the meal tray arrived in the evening, of course, the pea soup was there. So my grandfather dutifully decided not to eat the pea soup, but leave it on the side for the rest of the evening, and eventually they came and took it away. Well, unfortunately, that night, my grandfather needed to be worked up for his anemia, and part of that required a lower gastrointestinal series to see if he was bleeding. And as part of that procedure, they needed to provide him with an enema. Now, my grandfather tended to sleep on his side, and the position is perfect, and so in the middle of the night, my grandfather was woken up and provided his preparation for that procedure. Again, my grandfather, who spoke very little English, had no idea what was going on and assumed that they were actually giving him the pea soup that he had chose not to eat during the evening meal. And so I came in because I was just getting out of pharmacy school at the time with my dad, and my dad was chuckling the whole ride home after we saw him. And I said, well, Dad, what are you laughing at? He said, well, your grandfather has some good advice to you. If you're in the hospital and they offer you medication, you better take it. Otherwise, they'll sneak up and give it to you in the middle of the night. Well, if you think about this, these are the types of struggles that we have with patients that are on medications here in the hospital. And I'll tell you a little bit about some of the recent findings that we had. Okay, we're involved in the prevention of blood clotting events. And one of the most common events is blood clots here in the hospital. Many patients come in with risk factors. They're immobilized in bed. And so we typically try to give patients low doses of anticoagulant therapy to prevent those blood clots from forming. Unfortunately, those medications are all given by injection, and those are uncomfortable. So we actually were looking at strategies here in the hospital, how well we provided preventative measures for venous thromboembolism, blood clots. Okay? We really don't know much about why people develop blood clots or why they fail to receive preventative strategies in the hospital. One of the things that the government is looking at now is they recognize that blood clots are a common complication, and typically nothing is done. And so we decided to look at the barriers of why medications weren't delivered. And so we collected, and we do this routinely, we learn from you, we look at what goes on daily in the hospital, and we follow, by collecting information, the outcomes of care. And typically, we're trying to uncover practice patterns that we might be able to improve and reduce blood clots. Now, I can tell you here in the hospital, we've made tremendous strides in using the computer systems to improve the way we provide care. The most recent one was the introduction of computers for our nurses. So every patient that comes into the hospital gets a wrist bracelet with a barcode on it. The nurses all have identification tags with barcodes on it on the side, and the medications are all barcoded. The beauty of this is that every single dose of medication that's administered is impeccably archived in the hospital's computer system, so we know exactly what's given, the exact times of day. You may not be able to see this, but these are the medications that the nurses see and the times of day that they're administered, so we can get it down to the minute. And the computer helps the nurses by prompting them with alarms and signals to improve, adherence, to improve the way we deliver medications in the hospital. And not only that, when drugs aren't given, we typically prompt the nurses to give us a reason why the drug wasn't administered. So in this case, you'll see on this patient, it's recorded as not given. And we have a list of items that we can record in terms of what's administered. So in our study, we were looking to see if there were differences between an injection of low molecular weight heparin, which is an anticoagulant, and unfractionated heparin, or regular heparin, in hospitalized patients. That was it. We wanted to find out if there were late doses or omitted doses, and we decided to follow 250 patients here in the hospital, but they had to be here for at least 4 days, meaning they got at least 4 injections or as many as 12 injections as a minimum during the time that they were here. And we just simply looked at the number of doses that were given over the number of doses that were scheduled. And I can drill down and tell you that we actually performed very well, but there were some things I think that were important. We know that if we give a drug once a day, that the likelihood of getting the drug in is pretty high, about 95%. But if you give more than 1 injection, 2 injections, or even 3 injections a day, then all of a sudden the adherence or the ability to give the drug falls off. And even more surprisingly, we were somewhat disappointed that in order for these drugs to work, you need to take them 100% of the time, but the best we could do in the hospital was about 80% with a once-a-day injection and only about 50% in terms of twice-a-day injections. So we were kind of surprised by that. But the most surprising thing was not the fact that we didn't perform that well. When we looked at all the doses that weren't given and we followed up on all the reasons, the most common reason is the patients simply refused to take their medications. And that was a surprise to us because we just assumed the nurses would give those injections no matter what. And it turns out that if you sit there and you have to give yourself, and I've given myself injections, that over time you'll get weary and just simply say, I've had enough, we can do it again tomorrow morning. But that doesn't help us in terms of trying to prevent the development of blood clots. So obviously a problem. It becomes more magnified here when you look at all the other reasons. You know, we were hoping that there were other excuses we could come up with, like you were off the floor, or you were heading to surgery, or you had some medications that didn't warrant the delivery of the drug. But by and large, the biggest problem was patient refusal. So our conclusion from this simple summary, and this is why I say looking for you guys or the patients to provide assistance is enormous, that refusal is common. It was about half of the doses administered. We did better, obviously, by giving one dose. If a drug only had to be given once a day, it was better than having to give it 2 or 3 times a day. But only about half to 2/3 of patients or 3/4 of patients actually received all your scheduled doses. So this is the problem. The old Surgeon General, who you may remember, C. Everett Koop, said, you know, drugs don't work in patients who don't take them. And that is our biggest, you know, we provide these medications with the intent of providing benefit. Let me give you the scope of the problem across most medications, at least what we know in the field of medicine. Well, that if you put somebody on a routine medication, and it doesn't make any difference what it is, whether it's warfarin, whether it's a drug like Clopidogrel or Plavix to prevent strokes or blood clots, whether it's anti-diabetic medications like insulin or medications to lower blood pressure, over the long haul, people only adhere to their regimens in about half of patients. So out of about half of our patients will leave here and take their medications, about another half will not. Okay? Unfortunately, in those patients that don't take their medications effectively, about 1/3 to 2/3 of all hospital admissions are typically related not to the disease, but to the fact that the patients didn't take their medications. So it's a major problem. It costs the healthcare system a lot of money, and you can see the dollars here. And typically that doesn't come out of the patient's pocket. It really doesn't come out of our pocket, but it certainly has an impact on insurance and the overall cost of care. Let me drill down to some other subspecialties where it's been studied a lot. If you had a heart attack, we typically put you on aspirin, a drug called a beta blocker that blocks or slows the rate of your heart, and a lipid-lowering agent. Everybody seems to do well if we lower blood cholesterol or blood fat. But surprisingly, after a month, about 1/3 of patients will stop their medications. And after 3 months, about 10%, or 1 out of 10, will stop all 3. And you can see the lists of how well people use, but after about a year's time, about only 1 in 5 patients routinely take all their medications. Now that's a problem for us because we're a big hospital, we do lots of studies, and when we actually follow patients, like in the CHARM trial, patients do very well. They take all of their medications. Why? Because we follow them extremely closely. We have extra visits. We make phone calls. We record everything that happens. And so the care in the clinical trial setting doesn't really reflect what goes on when we send many patients home to their own devices. Just recently, this came out of a group here at Brigham and Women's Hospital. They went to CVS Pharmacy and followed 10 million prescriptions across 5 million patients. And the point here is when does the problem start? It starts as soon as you walk out of the doctor's office or as soon as you leave the hospital. About 3% of patients or 3% of the prescriptions were never picked up. About one out of 100 of those prescriptions are either anticoagulant medication like warfarin or antiplatelet medication like Clopidogrel, and patients didn't take it. New users were more likely to not pick up their medications. I can tell you that doesn't surprise me. If you feel healthy and we have you leave and you feel better, most people don't go get their medications. And then certainly the other thing that's become problematic and I think reflected in the Obama administration work to their health care plan is the more expensive a drug became, the more likely you were to abandon it or not pick it up. So as you get above $50, the price becomes a sting, and many patients simply don't get their medications. And as I suggested, some patients, even as a critical event like a heart attack, in 7,000 patients, 1 out of 6 failed to fill their prescription on the day of discharge. Okay, and the most common delay was about 3 days. But more importantly, when you didn't get your medication in your hand and start taking it at home, when we looked at those who took their medications versus those that did not, there was a twofold increase in a recurrent heart attack or death. And so the important message here is for us is we need to do better in the way we deliver our medications. Well, what are the barriers to medications in the hospital? Well, I wish I could tell you it's because the drugs are terrible, they don't work, cause side effects, and it's a major problem. The answer is that's not actually the case. If you look at the rates of bleeding, at least with anticoagulants or antiplatelet therapy, the major cause in about 85% of patients is nuisance bleeding, things like nosebleeds and gum bleeds, etc. The number of major bleeding events is actually relatively small, but that's enough to tip most patients over in terms of not stopping or not taking their medication. But if you actually look at the reasons, the most common reasons are the ones that we provide for excuses every day. You know, when my wife asked me, did you get the milk? Oh, I forgot the milk. You know, I forgot the loaf of bread. I've learned now, if I go out, I just buy a gallon of milk and a loaf of bread, and whatever I'm doing, I bring back, and I seem to be okay. But commonly, right, people forget. They have other priorities. The other disturbing element is people decide to omit their drugs. And in many instances, people simply have a lack of information. We know that as complexity grows with the number of drugs we take, the likelihood that patients will take them is less. We know that lifestyle has an important role in this, and what you do and the things you do day to day. Obviously, cost. I can't discount the patient to clinician relationship side effects. And then one of the things that we found in some of our surveys of patients here is that we never actually tell the patients what the benefit is of taking the medication. And I'll submit to you, if you've been on warfarin, there is no discernible benefit. Unlike having an antibiotic where you might have an ear infection or an eye infection or an upper respiratory infection, typically when you take those medications over time, you get better. I don't think I've heard anybody tell me they get better by taking warfarin. And so there is no discernible benefit, and that becomes more difficult to get people to maintain to a regimen. Now, the more you tease this out and you start dealing with psychologists and psychiatrists and then communications experts, you'll find there's far more to this than simply telling somebody to take their medication. We know there are issues with communications. We know there are economic issues. And then probably what I consider the most important is what are the motivational things that get people to do things. I know I can't get my children to pick up their clothes or clean the kitchen or put dishes away. Okay? So you need to find reasons to motivate them to do the things that you want them to do. And we've actually started to tease this out. So I'm giving you a summary today. Steve Barraletti, that worked with us for many years, spent an enormous amount of time teasing out the areas that needed to be addressed for not just one patient, but for every patient. And these elements of change, or the elements where you need to provide impact, differ from patient to patient. And as I suggested, some of it is related to the ability to pay and health care coverage, the cost concerns. We have many patients who simply decide to split their tablets and take half a dose, right? If they're getting benefit from a full dose, half must be as good, and if I cut it in half, the money is less. So many people do that. We have issues with communication in terms of providing directives to patients that don't speak English or have problems with literacy. And then, of course, again, as I suggested, the concept of understanding what each individual patient needs, what are the perceived needs, and then what our patient fears. Okay? And I can assure you that in your typical visit with your doctor, there is not a lot of time to try and find out what these issues are or what the pressure points are in individual patients. So those are things that we are working on now. There are other things that we have engaged on here. A company in Cambridge has provided this medication that is attached to the internet. It provides a light, flashing light. It provides a beeper. It transmits information to a central warehouse, and so we can prompt patients to take their medications. There are other devices now, the med station, a pill station, that you put it like you would an alarm clock. Not only does it alarm and whistle, but it also provides a screen of information, so you can put in information for patients that have monitoring requirements for things like diabetes. And then simple things, if we have to get to it, forcing or having a diary of filling out information so you know where you're at relative to recording. And you've seen these things. I think there are more now with the advent of the computer system and wireless technology that makes this far easier, especially with injections. But for some patients, just a simple pill box or a calendar-type package will do exactly what a patient needs in terms of the prompts. There are habits that people get into, and that's what we have focused on, that we recognize that there are things in your day that serve as a trigger. We often, if we are asking people to do things like stop smoking, we have to replace what they are doing with something else. So for some patients with cigarettes, it's a pen or a pencil to keep in their hand, a cup of coffee. We always need to provide feedback to patients, but this process tends to be slow. We look at small gains, 30 days, 60 days, 90 days, 120 days. We try to keep things consistent so that there are things that patients can be alerted to or build into their day. Take your medication when you shower. Take your medication with breakfast. Take your medication when your alarm goes off. Take your medication with Jay Leno at 11:30 at night. And when it doesn't work, we go back to the start and we try to find something that does. We've actually looked at trying to improve the communication, and this is one of our focuses of a study right now. And we recognize when you walk through the front door here, there is more than just people that are taking care of you, but other elements that you need to interact with, such as parking, such as getting to a location, getting through the pharmacy. Many patients have a poor understanding of the disease. They have a poor understanding of the benefits. They have a poor understanding of proper use. And then in sessions like with injectable drugs, there is discomfort. And so with the study that I talked to you originally about injection, we are actually now working on a small study where we go to every patient, and before they start their injections, we introduce ourselves, we explain what blood clots are, we explain what the medication does, we explain why the drug is important, and then we give them time to ask questions about whether there is issues, fears, problems, etc. And we follow that all the way through their admission and outside the hospital. So our intent here is the first steps in improving adherence. We've even put together a video to show patients on how, if they have to do their own injections with anticoagulant medications. I can assure you it's not a Nobel Prize or Oscar or Academy Award winner. And in fact, it's probably pretty close to pornography if you see me in this show. But it's, again, an attempt to show people that the medications that you have to inject, the medications you take, may not be all that difficult. I'm going to switch gears for the last few minutes that I have. Okay, so that's kind of where we're at with adherence. We have recognized that there is far more issues that are involved in providing care to patients and making sure that they take their medications. And many of those things start here in the hospital or start in the doctor's office when you arrive. And that's our time to try and provide the initial interactions with improving the way you take medications. 2 years ago, in 2008, there was a major breach of security in the preparation of the anticoagulant heparin. Many of you may know this. There was deliberate contamination done in China. Typically, the sources of heparin come from pigs, pig intestines. In those laboratories where the drugs or the raw materials were being obtained, heparin was contaminated with some similar chemical elements that caused close to 400 deaths here in the United States. That was enough to send a warning to the FDA, and you'll see now they are typically pointed to as moving very slowly, and the reasons they move slowly now is they are trying to ensure the public's safety. Okay? I'm not going to talk about that, but I can tell you that the system we used for surveillance actually worked, okay, to pick up that contamination problem, and it's called the MedWatch system. I don't intend for you to see this, but it's just the form. Every time there is an adverse event, an unexpected outcome, or an unexpected event with medications, the FDA asks us to fill out this MedWatch form and submit it to them. And then by collecting these forms, they see signals of individual drugs or classes of drugs that may be a problem, and then they go investigate. That's how they found the heparin contamination issue. The heparin contamination problem was probably going on for 3 to 4 years, but it took the accumulation of reports before they recognized there was a problem. The sad reality is the FDA receives thousands of complaints annually, but they really don't have the resources to investigate all of them. And then secondly, in their eagerness to ensure public confidence, right, they want patients to know that they're doing a good job, they've been reluctant to share complaints with the general public. Okay? So all I can tell you is this is the system that we have in place. It's the best we have right now. And there are other problems that come out with what the FDA does. I put this up because these are the standards for consumer information with medication. So when you go to your drugstore and you get a package or get a prescription filled, they usually give you tons of paperwork associated with it. Most of you throw it out with a bag, right, and don't choose to read it. Well, the FDA has gone through and criticized the information that's provided, both by the drug manufacturer and the pharmacies that provide the medications. And what I can tell you in a laundry list, this is what's supposed to be included in that information that's handed out. And the FDA found that in most instances, in many instances, even things like the ability to understand the information or even general information was only there about a half to 2/3 or 3/4 of the time. And so they've put in new standards now. And you will see this, I think, over the next several weeks and the next several years. They have put in a whole host of risk evaluation and mitigation strategies. That's complicated to say, but simply for every individual drug, there are different requirements. Some of them are a simple medication guide. Some of them are more complicated, requiring a communication plan to both the patient and to the healthcare providers. There are elements of assurance of safety, meaning that the FDA wants the drug company to collect information from you, okay, in different forms so that they can make sure that what they are intending to do is going to provide safety. And then, of course, if you're the company, you need to show that you've implemented and assessed these plans. Well, there is a new drug that Dr. Goldhaber is going to talk about in just a few minutes. It's called Pradaxa, and this is the medication guide. And with this new drug, the FDA is requiring the company that every time you have a prescription filled or you're given the drug, you need to be provided a medication guide. It's about 4 pages long. It typically focuses on the risks of the drug, which in this instance would be bleeding or clotting. And you can see what it is here. But this now is going to replace, in many instances, all of the information you get from the CVS pharmacy or the Walgreens pharmacy where you get your medications. Okay? And I can tell you for that drug, Pradaxa, part of the follow-up studies is for patients that go on it, the FDA has required that the patients will be surveyed at 6 months, 18 months, 3 years, and 7